nice little town. This is here. So we do a lot of burn prevention. It's one of the big pieces of our work. And so just help yourself after. These yellow cards are especially good. You can carry them on, when you're out in the field. And it pretty much tells you what you need to do as a first responder for burns. Some of the triage guidelines and fluid resuscitation, that kind of thing. So they're actually very helpful. We work pretty hard on them. They're condensed, but they have just about everything you need to know in order to stabilize an acute burn in the field. So we call this burn lecture Burn Care 101. Is a little bit of everything. We go into a little bit of the history of burn care because that's an important part of healthcare, and then we'll talk about about triaging burns, and then we'll go into the care of burns, both acute and I even have a little chronic rehab piece just because I wanted you to see the whole picture of what some of our pediatric patients go through when they get a burn injury. It goes about an hour and a half, which I know is really, really long. The average adult attention span is about 45 minutes, so we'll see how that goes. I'll try to keep things interesting. We actually do a lot of prevention. We do a lot of high school groups, and we actually have this is an EMS version. We have a high school version, and basically we took a lot of the gross pictures out, but you're going to see some of those in here. I guess Gene said that you guys are pretty tough, and you could probably handle it. So I'll weigh on her words and see how it goes. I don't have my clicker, but that's okay. I'll just do my page. Okay, so like I said, we're going to talk a little bit about the history, and I'll tell you about the Coconut Grove, some basic A&P. We're going to describe some burn injuries, when you're in the field, you know how important assessment is. We're going to talk about some of the actual burn characteristics. Fluid resuscitation is very important. It's basically the difference between life and death in an acute burn, anything over like 10-20%. And then we'll talk a little bit about how you actually manage the burn injuries, both acute and a little piece on long-term. We also have a piece on triage. Okay, so you'll see some wound products. I don't own any of the stock or anything, so I'm supposed to tell you that. Okay. So the Shriners is an organization. It came out. It was a fraternal group like the Knights of Columbus and Rotary and all that. That was very popular in the late 30s, early 40s, because they didn't have the internet, and this is how businessmen networked with each other, through these various fraternal clubs. And they always had, as well as getting together, they always had a community goal, and actually the Shriners expand beyond that to have a national goal. In fact, we have a hospital in Montreal, Canada, and Mexico City, Mexico, so it's actually international. So there's 22 hospitals. The 18 of them are orthopedic because that's how the Shriners started. You guys, when you enter the healthcare field, you're going to notice that nobody sits down in Washington and says, okay, how are we going to divide this money up evenly? It doesn't work that way. There's a lot of public relations in healthcare. It's things like when the AIDS epidemic, all of a sudden there was a lot of money for immunology research. There's, of course, the Jerry Lewis Telethon for muscular dystrophy. And even something like Christopher Reeves, when he fell off his horse, all of a sudden, because he's a high-profile celebrity, all of a sudden everyone's donating money for spinal regeneration research. So the orthopedic hospitals, back in they started these in the 40s, the Shriners group, said, what can we do to help? They always wanted to work with children. So they said, how can we help children? And in those days, everything was fee for service. In other words, if you didn't have money, you didn't get health care. If you had some kind of congenital or muscular dystrophy subtle or something like that, you would actually be warehoused at home, and grandma would take care of you. And that would be it. And anyone knows that if you stay immobilized for any length of time, you're really not going to live to adulthood. And so it was tragic for lack of a surgery or a brace or just regular rehab. a lot of these children wouldn't be able to survive. And so the Shriners started the orthopedic hospitals. And then right around 1968, they had grown even larger. They had some money left over. They have their own bank in Tampa. And they went back and said, okay, we have some money left over. Is there another area of pediatrics? And the Surgeon General then said immediately, yeah, we need to do something with pediatric burns. Because at that time, there really was no field of pediatrics. It was just like, if you happen to be a child, you would just go right into the regular, like universal ICU with the adults and everything. And as you know, Gene, children have a lot of special needs when they're hospitalized. And it really makes a big difference on how well they tolerate the hospitalization, how well they heal. And so sort of the field of pediatrics has evolved based on that. But really it was the Shriners. They started these first pediatric burn units and had a huge impact because, as Joan said, it's very specialized. So our own little Boston hospital is 30 beds. It seems like it's really small. There's the building. It's 8 stories. 30 beds is actually pretty big for burns because, as you'll see later in the presentation, burns are very complex and they require a lot of initial care and then a lot of rehab. And so with the 30 beds, we're kept quite busy. The 4-bed ICU is very specific. It's for burns that are greater than 50%. And we've had kids up to 95% burns that we were able to pull through. So that 4-bed ICU, a 95% burn, will probably be in the hospital for 5 or 6 months until they're completely healed and rehab. And so you can see how logistically quite a length of time and investment. The regular 8-bed acute unit, and you'll see some of these injuries, but they're all the smaller burns that they're usually in for like anywhere from they could be in for a week, 4 weeks, 8 weeks. And then of course it wouldn't be ethical. Some of these big burns, you can't like heal them and they're all scarred and they're immobilized. You go, well, goodbye, have a nice life. That wouldn't be ethical, so we have a plastic surgery floor to help these kids get through all the plastic surgery that they need. The one thing we aren't is we're not licensed as a trauma center because we would need like trauma surgeons and all these other, we would have to have a full like X-ray department, radiology department. So we contract services with Mass General, which is right across the street, and there's actually a tunnel joining MGH and Shriners, and so we're not. So that means that you would have to refer. But one of the things that we've noticed over the last 20 years, especially over the last 10, is the EMS has become so streamlined. The EMTs now are like very, very well trained, and it's amazing how quickly they can triage and transport to the ED, and then the ED, these kids will go in and get a quick trauma workup. But of course, the ER nurses hate burns; they don't want to really deal with them, and so they immediately shoot them over to us. So we usually, get these kids within 2 or 3 hours of their injury, where before it might have been even several hours. One of the things. This has happened about 10 years ago now, 2002. I don't know if you heard about it. It's in Massachusetts. There was a campground fire, and a 2- and 4-year-old, somehow the tent caught on fire. The 4-year-old ran out, the 2-year-old was trapped, and it was 100%. I don't know if you guys know MedFlight. MedFlight landed right in the ball field. The EMTs came in. They finally got the fire out, and they pulled this little 2-year-old, got him intubated, got IVs in. Really amazing. And then, bam, right over to the trauma, and then right to us. And then when we did our initial evaluation, we realized that this little 2-year-old was 100% full thickness. Not 1 square inch of skin was unburned. And you need to have that skin in order to transplant it. So we basically just kind of, set the IVs, and the little toddler kind of passed away. But that, to me, I know it was a tragic story, but it was amazing that EMS services could actually get 100% burn transported within a few hours. Really an amazing accomplishment. Basically we're a pediatric hospital. We have kids up to 18, but one of the things I said we do plastic surgery. A lot of these plastic surgeries, like if you're rebuilding someone's face, it's going to take like 2 or 3 years. You don't do it in one surgery. There's usually 5 or 6 surgeries involved. We would never have one of our plastic surgeons like stop in the middle of one of these operations and say, well, okay, you're 19 now, you have to go. So we actually can ask permission to extend it. That's really important, especially when you're doing this reconstruction. We just recently, within the last couple of years, we do we will take insurance, but we would never turn a child away who didn't have insurance. So we still offer no charge, care at no charge. Okay, so I told you about the history of burn care. This is the Coconut Grove fire. If you Google Coconut Grove, they actually have like a condensed version, but you can also, there's also a book called The Coconut Grove, and it goes into all the details of what happened. But it was basically a big nightclub in downtown Boston back in 1942. And it was really like one of these multiplex clubs. It had like 2 or 3 piano bars, it had a restaurant, it had a dance hall. And the owners of it did all the crazy things that you weren't supposed to do, like they blocked exits and that kind of thing. And so it was, okay. And so there were nearly 500 deaths in this. And you can see logistically, you know, the kind of triage that had to be done. I mean, there were victims arriving. I mean, the 2 major trauma centers at that time were Boston City, and which is now Boston Medical, and then Mass General. Okay, so they took the majority of these burn injuries. A lot of smoke inhalation. This club, what they did is there was a lot of paper decorations. They would never, ever in a million years allow that now. They even had gauze hanging off the ceiling, so it would look like clouds. It would be romantic. But of course, once that caught fire, you can imagine, you know, burning the cloth falling on top of people. The other thing is, this building had a revolving door as the main exit. If you go into any building in the country today, you're going to have 1 or 2 of the quick release doors on either side of the revolving door. That was a direct result of this fire. This nightclub didn't have that. And so, of course, everyone rushed these revolving doors. Someone fell, they went down, the doors got jammed up, and then nobody could get out. And so there were literally people 2 or 3 feet from safety who were trapped in the building just because of this revolving door. So you'll never see that in this country. You'll never see a revolving door that doesn't have a quick release door next to it. The other thing that was really tragic, the other main exit was in the restaurant, and it let out. But they just refurnished the entire restaurant, and they put in the fire door backwards. You know, any door that you see here, whenever you leave any kind of building, it always opens out. You know, if you go into an auditorium, a theater, a restaurant, anything, the main exit always opens out. Of course, if it opened in, everyone's rushing out, the door would slam shut, which is exactly what happened with this Broadway door. And once again, everyone was trapped. Just, you know, I mean, that should have been inspected, and you know, they should have got the check, you know, that everything was okay. And somehow the fire inspectors just never really got around to it, and they opened up this club before it was fully inspected, and it was a cause of, like, you know, many, many deaths. So, you know, we've learned a lot if you read that book, a lot of things in disaster planning and triage, a lot of things with firefighting technique within a enclosed area, a lot of course public safety, and sprinklers and fire doors and revolving doors and all those things are now very closely inspected before facilities are allowed to open. In the world of burn care, there is sort of a silver lining. As tragic as this accident was, there's a phenomenon whenever you have a mass casualty. And in this case, all these burn victims went to Mass General in Boston City, and they went on multiple floors because they had multiple ICUs, and MGH actually had the burn victims go to one floor. And Boston City scattered them around because they didn't want to overwhelm the caretakers. And actually, it was almost like the first burn unit ever. It was at Mass General. It was the old I think it was the old Warren 7. And so the same group of nurses and doctors and therapists all took care of these patients. And they actually, when they looked at everything, they did better than the patients at Boston City because they got really consistent care. It was sort of like a holistic approach. It just tells you that burn injuries are very specialized. And so they really do need people who have experience with it. So what happens is, all of a sudden the dust settles. You have multiple doctors, nurses and whatever, and they start to look at, who survived and who didn't, who did well and who didn't, and they kind of notice like, oh wow, this person that the victims that got the most fluid actually stabilized the quickest. They were least likely to go into shock. And so we really have to think about, giving these burn victims more fluid. And then they started the fluid formulas. That was a direct result of this. And then the other thing is, when you have a full, in the 50s, when you had a full thickness burn, what they would do is they would wait for the dead skin to fall off. They would literally wait for it to fall off. It would take weeks and weeks and weeks. They would try to scrub it off, but that was incredibly painful, and it really didn't work that well. You just, that dead skin turns white. It's like almost like leather. It's almost like you have a leather coating on you, and it just takes like weeks and weeks if it was to come off on its own. And so what they did is they said, if we're going to have these burns survive, because if the dead skin's on it grows bacteria, it gets absorbed, you get septic, and then you die of septic shock. So they really had to get this dead skin off. So somebody invented, the surgical technique, and basically now they go to surgery, they're put to sleep, and all the dead skin is scraped away, surgically, with actually they actually look like vegetable peels. I don't want to gross you out, but that's what you'll see a picture of it, and they can scrape all the dead skin off, and that way they're ready to graft. So the other thing is, after the dead skin finally fell off after weeks and weeks, the only way the skin could heal, because it was full thickness, so there's no more skin left that can grow. Normally your skin grows from bottom to top, but all those skin cells are dead. And so the only way for it to heal is from the sides in. It's called lateral healing, and it's very, very slow. And so now you waited weeks and weeks for the dead skin to fall off. Now you're waiting weeks and weeks for the skin to heal sideways to finally get covered. When it does, you get these big, thick scars that look really terrible. But that whole time, whenever you open it, they don't consider a burn victim out of the woods until they're pretty much all covered. Because anytime you can get a really bad, really bad infection, it could be an organism that antibiotics aren't very effective against, and they're already in a weakened condition. And so they lost a lot of burn victims from septicemia early on until they put these techniques together. The other thing, new things is new infection control. I mean, they just had like 2 or 3 antibiotics in the 1950s, like penicillin, Genta, I think maybe they might have Vanco. But now they have second, third generation cephalosporins. So basically what we do is, we culture the wounds, and whatever grows, we give them the exact specific antibiotics that they need, and the idea is to knock it out quickly as possible, and then you just wait for the next infection to arrive. And you have to be really diligent. You have to culture these wounds like twice a week, and anything that grows you want to knock out quickly. The other thing is inhalation injuries. I don't know if you guys have ever seen a mechanical ventilator. That's the things that actually can help you breathe if you're, for whatever reason, your lungs are badly damaged, or you're extremely weak, or whatever. You can't drive your own respiratory system. So they actually have a machine that helps you to breathe. So the old machines used to just push air in and pull air out, and that's all it did. But nowadays, all the mechanical ventilators are highly digital, they're computerized, and they can pretty much do anything. They can actually give you a breath and then actually hold it. They can do different mixtures of gases, and that kind of thing. So with this new inhalation equipment, because one of the big complications is if you have smoke inhalation. Smoke inhalation damages the lungs, and we had a lot of deaths from smoke inhalation, and it was called pulmonary failure, or burn-related pulmonary failure. So they came up with all this new respiratory equipment that's really helped to increase survivability. And then of course we have the specialized burn units, and once again, so all of these things have really increased the survival, so that we can actually get a 95% third-degree burn and actually pull that person through. Okay, so we're in the age of terrorism, and it pretty much can happen anywhere, but certainly, in the major cities, a target. You guys are just 50 miles from New York. So this was 9/11. There's the Pentagon down on the right. Okay. So one of the things they found out, I don't know if you ever, probably, you didn't read the 9/11 report. It was basically a fiasco. I mean, no one really said it. They were very brave, the policemen, firemen, and EMTs. But one of the things that the police got a mandatory order not to let anyone on site, and there were like EMS people who were trying to get in to save people, and they wouldn't let them. So dozens and dozens of people could have died without getting that first responder care. And in a way, though, they were vindicated because the towers did collapse, and if the towers collapsed, a lot of EMTs probably would have been killed, but no one could have foreseen that. So they just sort of said, listen, we really have to get our act together. We have to communicate much more, much better, during these type of incidents. So good communication. The transfer of burn patients, one of the things is, you know, you have to send the worst burns to the verified burn units, the burn ICUs, and then the not so big burns will go to the regular ICUs, and the smaller burns will go to the regular, you know, maybe the med-surg floors, you know, 10. So all that has to be decided, and that has to be communicated to the EMS services. And then not only that, but after some of these patients stabilize, probably within like anywhere from 2 to 3 weeks after, these patients will be shuffled around. You know, if they get better or worse, they may have to go to an ICU. And so basically EMS is going to be very busy for, you know, for at least, you know, a month after one of these incidences. It just, you know, it's not the first 2 days, you know, it sort of goes on and on. So one of the things we found out is if the towers hadn't collapsed, there could have been 3,000 burn victims. And we only have the capability of taking 1,500. That's you know, all the regular logistics, the supplies you need, the training. You know, there's something they call burn beds. Most trauma centers have something they call burn beds, and so we only had 1,500, which means that half of those burn victims would have gone into the general population and probably wouldn't have received the best care, you know, the care that they really needed. And of course, their survivability would have been, you know, reduced. One of the things, burn injuries, they are common in disasters whenever you have explosions. I know you guys heard about the marathon bombing. We didn't get any kids from that because there were actually 9 kids who were burned, but their burns were relatively small because the gunpowder blew upwards rather than outward. If it had been another kind of accelerant, there probably would have been more burns, but it was just the nature of that type of explosion. And so the kids that had burns were relatively small, but they had a lot of, there was a bad concussion. So they had a lot of concussion damage, you know, ruptured organs and spleens and that. So they went to Children's, and then we sent doctors consulted with their doctors on how to take care of the burns. But they kept those kids because they, you know, some of them lost arms and legs and that kind of thing. And so that tissue trauma took precedent over the smaller burns. If they were bigger burns, they would have come to us. So they are common. 1/3 of those hospitalized at the World and Pentagon had burn injuries. So out of all those injuries, at least 1/3 had some burn component to it. Burn injuries aren't like others. It just takes a really long time. I mean, they have to get all the dead skin off. They have to take any skin that's unburned and graft it onto the burn wounds. It takes 2 weeks for these burn grafts to heal. And so logistically, there's a lot of time that's invested. Basically, what it comes down to is for every 1% burn, you're going to spend 1 day in the ICU, and that's just till you're covered. Then there's all the rehab stuff after. So basically, you're not out of the woods. If you have a 50% burn, you're not going to be out of the woods for almost 2 months. You know, that's a long time to be sort of hanging there, but you know, it's that kind of injury. This is very busy. I'm not going to go over it. It's on these yellow cards, but it's actually very important. It's a referral list and referral guidelines. But basically what it says is if you have a burn and in any way there's a complication connected to it, then they really should go to a verified burn unit, because even a major trauma center, where's your trauma center around here? What's your name?
Bridgeport.
Oh, Bridgeport, okay, right.
They have a burn unit.
Oh, yeah. So Bridgeport would probably see maybe, like if it was something like a chemical burn, they might see like, you know, 6 or 7 a year. Well, we probably see 50 or 60 a year in our little hospital. That means that we developed a real body of expertise. You know, with all of these complicated burns, we see a lot of them compared to even a medical center. And so really what it says is, when you have these complicated burn injuries, they really should go to a burn unit, you know, where the doctors and nurses have really seen a lot of this. So that's pretty much what that says. It really is important. Okay, this is some statistics on how and who gets burned. Nearly 500,000 burn injuries a year. Of course, a lot of them are pretty small, you know, don't need extensive care. But 40,000 out of those are treated in the hospital, and the rest are treated on outpatient. And then out of that, 3,500 people die, and most of them are from house fires. The harsh reality of a house fire is if you don't escape a burning building, you don't end up with a 5% burn, you end up with a 70 or 80% burn, usually with really significant smoke inhalation. And so you really get hurt badly if you get trapped in a burning building. And then you have motor vehicle and also some really bad. The contact is like really high voltage. Sometimes scalding liquids would be like a big pot of spaghetti sauce that goes right over a toddler. And then some really, really bad, contact burns, but they would have to be like a major contact type of burn. So this is it. This is what that's actually, I forgot to change to 211. I changed the pie chart, but I didn't. It's 2012 because I updated this. So last year, 2012, you can see all the skull injuries that we had. I mean, there's a lot of skulls, and you'll see that in a minute why. Some flames, some contact. Contacts is like when you touch the pot. Flame is when you get burned by fire directly. Then you have electrical and chemical. They do follow developmental stages. So the infant is pretty much, pretty dependent. Really, they can't like crawl or do anything. They're usually being held, just very basic behaviors. Where they get injured, house fires statistics are on the top, but of course they're a lot less frequently. But like I said, the house fires on the top because those are the biggest burns. So an infant couldn't escape a burning building on their own. So unless their caretakers or the first responders actually went in and saved them, then they're going to be like trapped in there on their own. The scars usually aren't something that they pull on, like the toddlers. The scars are usually, one of the caretakers is holding the infant and they're running around and something gets knocked over. The other thing is tub scars, which I really, really hate. We have some prevention things where you can actually measure the temperature of the water. Just to let you know, I don't know if you guys do any babysitting or anything, but I know that, after a hard day's work or a hard day at school, you want to come home, take a hot bath, it feels really good. But babies don't need hot baths, they just need warm water. You wash them up really quickly, you dry them off, you put the PJs on, you put them to bed. I don't know how this thing, it still happens though, it's amazing that people will put an infant in hot water. The infant's keratinized layer, the skin layer, is about 1/3 less than ours because the skin is just thinner. So where you might get a first-degree burn, it's very likely that infant would get a second-degree burn with blistered skin and all of that, kind of thing. Where they would really have, spend quite a bit more time healing. So yeah, tub scars, just really bad. Okay, the infant starts to crawl around, explore, they get a little bit better hand-mouth coordination. Once again, they can't escape a burning building. They do get scalds, and still there's a lot of spills and that kind of thing. They still get tub scalds. They start to get some chemical ingestions and electrical injuries. The electrical injuries, one of the things we do, and actually, I don't know if EMS does it, but the emergency room nurses do quite a bit of it, but they collect trauma statistics. There's a website called the American Academy of Pediatrics. It's an awesome website if you're ever involved in pediatrics, but they actually collect trauma statistics on everything, on like poisoning, falls, all of those things, but they also collect burn statistics. But one of the things that we see patterns, one of the things we saw way back in it's like the 60s, 70s, when we first came around. But they used to have the wiring, you guys are way too young, but the wiring on lamps and stuff, like regular household appliances, they had a vinyl coating on it. It was like the thickness of saran wrap. It was ridiculous. But that's what the manufacturers got away with, And so the kids could bite through it. Nowadays they have UL coating, and so wiring is much, much denser. It's really hard for any kid to chew through it. But they would chew through this vinyl covering, and they would get little electrical burns in the corner of the mouth. But it's very difficult to repair because your mouth is radial muscle. And so it's almost like in Batman the Joker, it's that kind of like really bad injury, because then it's very difficult to repair. Then they can't speak funny, they drool a lot, they can't eat well. I mean, it's a really nasty injury and it's really difficult to repair. Okay, so these are the bad boys of burn care. I don't know if any of you guys have toddler siblings or cousins or something. Just watch a toddler sometime, though. They're pretty amazing. Not only are they very lightning fast, but if you ever watch them, they're like 2 feet high, but they have like a 5-foot reach, like they're made out of rubber. It's like unbelievable. You just watch them sometime. It's like incredible. So they were always like, parents, even parents that are being conscientious will move something, but somehow that toddler will get on a chair or something and reach it. So they're always getting in trouble, not just with burns, but with everything. One of the things is they have no formal cognitive processing yet, which means basically they don't have any common sense. You tell them something's hot, and they forget it 2 seconds later, unless they get burned, and then unfortunately they do remember, but that's called learning the hard way. So this is a very high-risk group. It's amazing. Like 60% of our admissions are toddler scholars. It's that 2 to 4 year old range. They just have to be supervised very closely all the time. Don't worry, I expect this. Okay, I expect this because I do a lot of these EMS groups. It seems like it happens every time. Well, that was a pretty large group. What was that, 2?
One will go out and the second one has to get dressed.
Okay, I see. You guys got to slip up, right? Okay, so the toddlers, once again, a toddler can't escape a burning building. In a lot of these injuries, there's a subcategory that's particularly bad, and in this skull toddler category, it's the pot handles, okay? What happens with the pot handles is, it's not just like an 8-ounce cup of coffee that's hot. Usually cups of coffee or tea only cause a second-degree burn because they're only not boiling. So one of the things, when I first came in, I've been
Massachusetts Post 53 on your first response. Yeah, normal travel. Number 231 Old Kings Highway South. Hindu for a 77-year-old male from fall, possible witnesses. Repeating dispatch, Post 53, your first response. Yeah, normal travel. Number 231 Old Kings Highway South. Hindu for a 77-year-old male from fall, possible witnesses.
Somebody makes that announcement, is that in the field?
And number 231 Old Kings Highway
Why is that so wearing Jackson will know you're on the big side.
Good luck to you. Done?
You're done.
Okay. So the pot handles, so what you would have is you would have like a quarter tube, like spaghetti sauce boiling on the stove, and the toddler would reach up and flip it over. And if they were lucky, it might just get them in the shoulder or miss them. But a lot of times it went right over the top of their head. So what they ended up with was a full thickness facial skull, which means that they're going to have horrible scarring. So this beautiful child is going to be horribly scarred for the rest of their life. No way around it. I mean, as much as they try to do cosmetic surgery, when you get a full thickness burn to the face, I mean, you lose like your nose and your ears and stuff like that. It's just really horrible. So they were getting these quite frequently. And so Warner Brothers and the American Burn Association, the Shriners, got together and they put that commercial together. It's like with Bugs Bunny and Daffy Duck turn the court. You guys are way too young. I haven't seen it now for at least 10 years. But when it first came out. But anyways, I do a lot of students, and we do high school students, and we ask them, and almost every time everyone raises their hand about turning the pot handles in. So whatever it is, sort of a generational thing. You guys all know that you should turn the pot handles in, right? If there's I don't know how you learned that, but everyone seemed to get passed on. So whatever that prevention endeavor was, it was certainly worth it, because we have seen like 500% less of these type of injuries. I mean, it's a huge difference. We might see 1 or 2 a year now, where we used to see like a dozen, and they were horrible. They were horrible burns. So prevention really does work. Oh, I lost my arms. Okay, good. Thank you. Okay, preschooler, 3 to 6 years. one of the things with them is they do have common sense, they do listen, they understand, but they still get in trouble because they're so energetic. One of the things in their characteristic in their development is they're highly imitative of adults. They want to do everything they see their older cousin do, or their mommy, daddy, uncle, aunt, and so they're very, very imitative. They still can't quite get out of a burning building on their own. They still get some scald injuries, the younger group, because it is 3 and 4. Some contact burns because they're running around and they may fall again. But the big one in this subgroup is the match play and clothing ignition. So that's why we have the safety lighters, the safety matches, because if you ignite your clothing, it's not going to be like a 5% burn. It's going to be a big 30-40% anterior torso. A lot of times it burns up underneath the neck. The neck is a really bad place to burn because when you get scars, you need a lot of plastic surgery to be able to move around again. So they're nasty injuries. Clothing ignition is really, and it's almost always full thickness, 3rd degree, because it's burning cloth right on the skin. So this is the less than 5, okay? So you can see all the tremendous amount of scalds in this age group. So, you just got to be really, you got to supervise well and be really careful. You can see the contact burns, and, if you have a wood stove, it's common sense that if you have kids around, you need to put some kind of barrier around it. I mean, there's just a really good chance, especially if they're running around playing, and, anything like that, any kind of hot element or something, you got to be really careful with that small kids around. And then not that many flame in this age group because they really aren't playing. That's really the older age group, and a few chemical and electrical. Okay, so school age is like, we focus the bulk of our prevention on this age group. So they're like very, very responsive. They think it's really cool if you're a doctor or a nurse. They think it's cool if you're an EMT or a fireman or a policeman. They just really, a very responsive group. And they're very, precocious. They really do understand what you're telling them, because we see it statistically. So we teach them stop, drop, and roll. We teach them the escape route, to get down low in a burning building, that kind of thing. And believe it or not, they remember all that. They're real advocates. They're the kind of, like when we do our prevention, we'll tell them about smoke alarms, and then they go home and they'll go to their parents, do we have smoke alarms? We got to go to Kmart now and get smoke alarms, They really advocate. It's just really an interesting age group. They're very responsive. They do get in trouble. We see statistically, though, with the house fires, that there's actually a significant drop in the individuals getting trapped in a burning building or burning pot, whatever, because they have that kind of prevention. They know, or they hear it on TV or whatever. When they get it, they get it, they remember it, and they know what to do if they get caught, especially if there's a smoke alarm. Smoke alarms are like really important. And then some match play, fooling around, that kind of thing. And some scalds, usually it's like maybe accidental underfoot shower, stuff like that. But really, it's a really responsive age group. So that 5 to 13, we do get a lot of flame burns, and you'll see why. That's really part of the next age group. Some scalds and contacts and that kind of thing. So this is it. Okay, so here we have these toddlers that have no common sense. Then we have the school-age kids who are really very responsive and willing to listen to what you have to say. They respect adult advice. And then you hit adolescence. Well, the big thing with adolescence is basically you're trying to develop your own identity. You want to be independent. You want to be like an adult. And so you really have a tendency to come on, I know, I know I don't have to do, But the thing with this age group, the thing that gets them in trouble is they think they know more than they do, and it always sort of messes them up. Like, if I took gasoline and put it on the floor and ignited it, it would kind of burn off. But if it's in a container and I'm pouring it onto a campfire, basically you have a bomb when it's in the container. What happens is it ignites in the container, it expands, and then liquid fire just shoots out everywhere, and it hits everybody, or whatever. So they're really getting a lot of trouble with that. A lot of conflict with parents, a lot of risk-taking behavior. If you watch some of those shows with the BMXs and the skateboarders, they just like really do some dangerous things. They do escape a burning building, but a lot of gasoline-related injuries, especially it's like 95% male though. It's very gender specific. For some reason, guys like to play with fire, girls for some reason don't want to play with fire as much. It's got to be some prehistoric thing or something. But so you do get clothing ignition. The clothing ignition with gasoline on it is really bad. You're definitely going to get a 3rd-degree burn. The explosive thing, the internet, this has changed. It was more common 10 years ago when the internet really got popular, but there was a lot of websites. There was one, we had 2 cousins that came in about several years ago, and they went online and they got a formula for making napalm. It was basically liquid soap and gasoline, and you put it in the pan. Don't do this at home, by the way. And they put it on the stove and turned the heat on. They wanted to go into solution, so they would have like liquid fire that they could put in a squeeze bottle and then squeeze it. But of course, the thing blew up. And so I'm talking to one of the kids, and I go, "Why you put gasoline in the stove and you turned it on? Like, why would you do that?" I don't know. It's like, no, really, why did you do it? Well, it was on the internet. It's like, well, who wrote it? Was it a chemist or something? Or you don't know who wrote that. So we've found things like how to make pipe bombs, how to make hand grenades. Of course, these marathon bombers got the pressure cooker bomb recipe off online. But anyways, the reason why I bring this up is you guys are all going into healthcare, especially emergency trauma, which you want to always prevent. So if you come across one of these websites, you can forward the website to the state fire marshal's office or the state police, and then they'll actually investigate the website and see if it has to be taken off. Because if it's on there, some kid's going to do it. Not one of you guys, of course, because you're too smart, but some other kid will. Actually, the kids that do it are pretty precocious thing, but they just don't have a lot of common sense sometimes. So this is this age group, so you can see all the flame burns, just a lot of gasoline play that gets out of hand, some scalds, and then some contact injuries. Okay, so that's the etiology. That's who gets burned. Adults get burned, usually it's work-related, and then older people get burned. It's funny, the circle of life, they also get a lot of scalds. It's not because they don't have any common sense, but their hand coordination, they might also be on like different drugs, or the drugs might be adjusted, drugs that they need, and they may be smoking on the sofa and all of a sudden fall asleep, or that kind of thing. The other thing is, all of a sudden, that incidence of getting trapped in a burning building increases in geriatrics. So nowadays, if you're in a geriatric facility and you're transferring someone home, they should always evaluate the home situation. They definitely should have smoke alarms, definitely, but also they should also have an escape route, and they should know how to escape a burning building. And then also the fire department, EMT service, a lot of times they'll actually say if there's an older person that's high risk in the neighborhood. Okay, so you guys are all in trauma. You know the ABCs, it's always airway first, breathing, and then circulation. That's the things you have to evaluate. Disabilities, if you have any neurological impairment. Exposure is if you have any secondary injuries. You're always going to do a full body, very quick full body assessment. So in airway and breathing, really what you want to know is, do I have a patent airway? Has smoke inhalation compromised the airway in any way? And also inhalation injury is actually lung tissue damage. So has the lung tissue been damaged in any way? Am I going to be compromised somewhere down the line? So three of the main types is this regular carbon monoxide poisoning. That's when you breathe that smoke in, and basically the carbon monoxide knocks the oxygen off the hemoglobin molecule. And so the only way to treat that is if you pull someone out of a burning group who you suspect has smoke inhalation, you have to put them on high flow oxygen, 100% oxygen. And that way you supersaturate and you knock that carbon monoxide off. The only way you can get the carbon monoxide off is by 100% high flow oxygen. Inhalation above the glottis, you just do an oral inspection, you have to watch them closely. It's not bad if you have like 1 or 2 victims that you're going to transfer within an hour. When that becomes a problem, it's mass casualty, same below that glottis. That usually happens further down the line. What happens is some of the smoke has toxins, and it actually damages the lung tissue. It actually, breaks it down. Later on, that lung tissue is going to scar. So anyone with either above or below is going to be ventilated. Above the glottis, once that swelling goes away, they'll probably be okay. But some of these inhalations where you actually get lung damage, tissue damage, they're going to be in the ventilator for weeks and weeks. And we do have it's a very rare situation, but it does occur on rare, is that they get such bad lung tissue damage that the lung tissue actually scars. It's called pulmonary fibrosis. And if they lose enough lung tissue function, they can never be taken off the machine. But you can't keep someone on those machines forever. And so as the scarring gets worse and worse, you would have to increase the pressure, but at some point you just can't make it so high that you'll actually damage the lung tissue just by giving them so basically we have a certain set point, and then we stop at that set point, and if they can't survive, then what happens is the CO2, carbon dioxide, builds up in their bloodstream, and they basically go into cardiac arrest. But that's very rare. We're actually one of the situations where they've sustained such significant lung damage. And this always happens like 2 to 3 months after, because it takes that long for the lung tissue to scar. And then that's about the time when we try to extubate them. And then all of a sudden we realize, well, they can't survive without this machine, but we can't keep them on the machine forever. So it's hard, but that only happens, I think that hasn't happened now in a few years, actually. House fires in general have decreased because of mandatory hard wiring and stuff. So we actually, I think we almost prevented ourselves out of work, but we still have lots of toilet stalls and contacts, but we used to get 5 or 6 house fires a year. Now we might get 1, sometimes 2, So it's really, all this legislation that goes through really works. Okay, so these are the signs. If you see any kind of clothing ignition, singed nasal hairs, eyebrows, you can always do an oral inspection. If you see redness around the lips, the tongue, the inner part of the mouth, if you see face, neck, chest burns, any kind of stridor or difficulty breathing, you're going to really watch that person closely. You're going to have them on an O2 sat monitor. And then once they get to the trauma center, they're going to do carboxyhemoglobin levels. And that just basically tells you how much CO you have in your bloodstream. So there is a relationship between burn size and inhalation. The larger the burn, the more likely it is that you have an inhalation injury. And that's because those big burns are always going to be like a house fire, a motor vehicle fire, that kind of thing, where you get trapped in an enclosed area. So this is a triage piece that you have to remember if you're ever in especially a mass casualty burn, but even if it was a family. You can see that this is the same 1 centimeter of edema, and this occurs within 2 to 3 hours after the injury, so usually you would have a safe window, because you're going to be like an hour transport right to Bridgeport, if anywhere around here. But if any reason it was delayed, within 2 or 3 hours, you're going to begin to get this airway edema. This is the cross-section of the trachea. And so you can see that little infant, it's going to be 75% closed off, and the adult's going to be 40%. That adult can probably breathe on their own. They might need some bag masks to help them, but that infant's going to be in serious trouble. If they're not intubated, they're probably not going to survive. And this is probably 3 hours out of the injury. And so what would you do? You always evacuate the infant first, then the child, then the adult. If you have an infant, a child, and an adult all with smoke inhalation, the infant goes first, the child goes next, the adult goes last. Okay. When adult, we do say intubate. That's when they have significant stridor. I know that nowadays, some EMTs get trained to intubate, which is great, but they always say generally it's good to have them intubated in the trauma center, where you have like an anesthesia doctor who's done it like 1,000 times. If you can't, then take a shot at it. But if you could bag mask and sort of maintain them, then I would go ahead and shoot to the hospital. But if you have to pull over and intubate. But if you really think that they need to be intubated to maintain a patent airway, it has to be done. Okay, escharotomies, kind of a weird thing. Okay, it's almost hard to think, but when you have a full thickness torso burn, at least 2/3 of the way around, then that's like wearing a leather vest. And as you begin to get fluids and the edema builds up underneath the soft tissue, the lungs actually get squeezed shut. Like I was telling you about the mechanical ventilators, they're all digital now. So you can actually see that. So you have a burn victim that comes in that hasn't had escharotomies, and they have a big torso burn. And so the machine tells you what the tidal volume, which is how much oxygen, how much air is going into the lungs. And the average for an average size adult is about 700 cc's is what fills your lungs. And you can actually see the thing drop like 600, 500, 400. It's like, whoa, we're almost at half the capacity, And so they get the burn surgeon, they run out, they do the escharotomies, they split open like that, and all of a sudden it's back up to 700. So this type of thoracic compression from burns is a reality. It can actually kill somebody. It'll just suffocate them because they won't be able to breathe with their lungs crushed shut. Some EMTs do take a special course. They take a trauma course and they're trained to actually do escharotomies, but you have to actually practice doing it. And then they have Bovie pens that they use. But once again, you would always want a burn surgeon or a trauma surgeon to do this because they've done it before in other ways, or they've done regular chest surgery. So only as a last resort. That's the carbon monoxide. So probably if you don't smoke and you live in Darien, it's probably 0. If you don't smoke and you live in Boston, it's probably 5. But it's really once you start to get up to 20. That's this is percent of your blood that has CO in it. Then you begin to get headache. 40, you begin to get other more significant. But if you see the big one, when you start to reach 40, 50, you have to be in a burning building, breathing smoke for several minutes for that to happen. But then you have confusion, and that's when you fall down the stairs or you walk through the plate glass window. And so anyone that's suspected of having high CO, you're going to do your full trauma workup because there's a good chance they might have associative trauma because they are confused running around a burning building. Okay, circulation. So now your airway breathing has been addressed, and now you have to. So circulation is very big in burns. Whenever you do any kind of trauma situation, you're always going to do your baseline. Your peripheral might be cap refill, central pulses, peripheral pulses, that kind of thing. You look at skin color, of course, heart rate, blood pressure. But then you're going to obtain IV. So yes, you want to maybe get 1 or 2 large bore IVs because you are going to be giving a lot of fluid. You can put an IV through burn tissue. You always look for like non-burn tissue because it's going to be easier. But you can start an IV through burn tissue. It's just you have to it's just more difficult, but you can do it. You might have tried 3 or 4 times. Nowadays, you guys all know about IOs. We've actually seen IOs a little more frequently because, especially with some of the smaller burn victims, if they're not resuscitated very quickly, they go into peripheral constriction, and then it's really, really hard to get an IV started. So they make 3 or 4 attempts. If they can't do it, they put an IO in. And IOs are actually very effective because you can give quite a bit of fluid using an IO. You might even have to use 2 IOs. But you got to have that IV access. Again, you guys aren't going to be in too much trouble with a 1-hour, transport. If there's ever any kind of mass casualty, though, it's going to be a real challenge because you're going to have to get some kind of IV access if you're going to save that person. And of course, fluid loss begins at the time of injury. Once they get to the hospital, they're going to have a central line, A line, keep them warm. We watch them very closely, and then you might have started fluids, but we'll actually, reevaluate the resuscitation status. So a lot of we use LR, we use the Parkman formula, but this isn't unusual for like a 60-70% burn for 50 kilogram victim. Might need that amount of fluid within a 24-hour period. It's pretty extraordinary. So the things you have to do is you have to determine the size and depth of the burn very quickly, and I'll show you how you do that. You kind of determine the weight, Then you have to get IV access. Later on, we insert a Foley. You may not do it in the field. And then we begin fluid resuscitation. One of the things that happens is there's multiple mechanisms for fluid loss. In a nutshell, fluid is everywhere you don't want it to be. It's extravascular. You lose fluid through the open wounds. There's even a cellular shift of fluid where fluid leaves the cell and goes into the soft tissue. And so you have a lot of soft tissue edema, and you're losing intravascular fluid, which is what you need to maintain perfusion, organ perfusion. So all these burn units have they develop a lot of specialized formulas, and they all work, but there is an indication. The reason why we use the Parkman formula, I know the Evans formula is hypertonic. They use a lot of hypertonic. They use stuff like something called Dextran that has glucose in it, because glucose is a high density solution. We use the Parkland, which is just regular LR. It can be normal saline too. The reason why we use that is because it's considered to be like a pediatric formula. One of the problems with these other types of solutions, these hypertonic solutions that you use, they make great volume expanders. What happens is, in that first 24 hours of burn injury, you get capillary permeability due to the trauma. That means that anything that you put in the body is going to get third space to the soft tissue. And if you get something that's hypertonic in the soft tissue, it's only going to draw more fluid. So what happens is if it's a kid that's like, 25, 30 kilograms, they're going to look like a giant puffball. I mean, the edema is going to be overwhelming for them. I've seen kids that had face burns and their heads look like a watermelon. So we kind of stay away from it. If we have to give like a colloid like albumin, we will, but we don't make it part of our Parkland formula. And so with kids, you have to be a little more careful with what you give them. A bigger adult can handle that kind of edema, but a smaller child's going to run into trouble. So here's the Parkland formula. It's 4 mils LR times the weight in kilograms and times the total, that's the total burn surface area, so the size of the burn. So then you take whatever that is, you divide it in half, and you give half over the first 8 hours, and then the second half over the next 16. Just to let you know, the American Burn Association is working on, they think that this might be too complicated, or, so they're actually thinking of once you get the, like whatever the formula tells you to do, that you'll actually give a single amount. You won't divide it, and then you'll adjust the formula as you need it. So like, say like you came out to like, the person needed like, 1.8 liters. They would say, okay, that person needs 250 cc's an hour. And that's what they would, so you'd actually have like a little chart that told you to make it a little bit easier. But for now, we have the Parkland formula, and we're still using it. The Parkland formula is on the yellow card. So that's it. So you have a 50 kilogram kid with a 75% burn, okay, times 4 cc's, and you do the math, and it comes out to almost 15 liters. A lot of fluid has to be given over 24 hours. Okay, this is probably like an 11, 12-year-old. So the first, you divide it by 8, that means that they're almost going to get 1 liter per hour for the first 8 hours. And in the next 16 hours, they might get about half a liter. Because the formulas aren't an exact science, you have to watch them closely. So over-resuscitation can cause pulmonary edema in an older burn victim. We do kids, but in an older victim, it could be congestive heart failure. Under resuscitation, they're going to be hemodynamically unstable. In other words, they're going to be shocky. And so it's kind of like driving a car down the road. You have to kind of keep it in the middle. Next slide. Yeah, so one of the things we do, if any of you guys go into trauma, especially like an ICU nurse or an ICU doctor, we call urine output our golden window. And the premise is, we put a Foley in, we definitely want to get a urine output. In fact, 40, 50 years ago, when you had a big burn victim, they didn't expect that person to have a urine output for like 2 or 3 days. Can you imagine? That means all that time, those organs are underperfused, and if you have underperfused organs, they're going to be damaged, okay? And it actually can go into multi-organ failure. So we call urine output our golden window, because the premise is, if your kidneys are being well perfused, then you're going to make urine. If your kidneys are being well perfused, then all the other organs are being perfused. And so therefore, if you have a urine output, then you get good overall organ perfusion, which is what you want. If you don't get good organ perfusion, those organs, they may not fail, but they're certainly going to be damaged. And if they stay damaged, if they get damaged enough, then they will fail, okay? And then you'll have a really nasty situation. It's called multi-organ failure, and then you basically die. And we do to an NG to decompress the stomach and, hypersecrete. So initially we do that. Okay, disability. So we do a quick neuro exam, we check the spine, we do a trauma workup. Actually, we don't do it. This is what's happening at the trauma center. And then they take full body x-rays and that kind of thing. We check to see if they're alert and oriented. We evaluate the head injury, carbon monoxide. They do that carboxyhemoglobin test. And then we question substance abuse, any kind of hypoxia due to head injury. Exposure. definitely remove all the jewelry, because that edema is coming. You know, within 3 or 4 hours, that ring that's on there isn't coming off. We have a special, I don't know if you've seen it, the ring cutter. You put it in and you cut it away. I've done that like several times because they, you know, they just forgot to take the jewelry off. But you guys are too good for that. So yeah, get all the jewelry. I mean, it's definitely the circumferential jewelry, any kind of, you know, bracelets, anklets, and rings and stuff. You want to keep them warm. There's a fallacy that burn injuries, like when you transport them, that you have to keep them wet, you have to keep them cool. That's not true. Of course, initially you have to, if anything's burning on them, or the clothes that have been burned, you want to take those burning clothes off. You want to take those hot clothes off. But once that's done, those wounds are going to begin to weep. And basically, on a wet surface, you lose heat 4 times faster than a dry surface. So what would happen is they actually would put sheets on these burn victims and wet them. And I know if you burn your finger and you put it in cool water, it feels better. But in a big burn, you can't do that because they lose so much heat. They actually clamp down peripherally, and then when they hit the warm ER, they did something called rewarming shock, because everything expands again, and they actually can go into shock when they get rewarmed. And so it's really important that they stay warm. So I would put some a sterile drape over them, and then a couple blankets. I would heat the ambulance, keep that warm, and transport them so they stay warm. I remember getting kids that were like 97.2 and stuff like that up the transport. And the thing is, you can't do anything until you heat them up, so we'd have to put the warming blankets on. And then finally, when they got warmed up, we could, you know, start to evaluate the wounds. But sometimes it would like take, you know, 30, 40 minutes to warm them up. Okay, wound assessment. So these are the 3 things we ask ourselves. What kind of burn is it? How bad is it? And how big is it? Okay. So these are the burn types. You have 4 major categories of thermal, which is all the flame stuff, chemical, electrical, and radiation. Radiation is like sunburn stuff. It's not like atomic radiation, which I hope I never see, by the way. But anyways, okay, so there are 5 subtypes. There's flame of thermal injuries, direct flame, if you get scalded from hot water, steam is very hot, contact burn from a hot object, and hypothermia. We don't see hypothermia too often in pediatrics. So here's a flame burn. So I don't know if this has it there. Is that there? Oh, it does. So all this is called eschar, or avascular tissue. It's all white because all the blood supply has been destroyed. So all this is coming off surgically. And they're going to take skin probably from the other side here and split it in half. You'll see a picture of it. And take off, and then flip it over and put it on here and let it heal, okay? And that way you can only get covered by your own skin. We do have like artificial skin called biological products that we can use to temporarily cover, but eventually only your own skin will heal to your body. It's very protein specific. So I couldn't take skin from Joan and put it on me. It would stay on for like, you know, maybe 4 or 5 weeks, but then it would eventually fall off. So you need to have your own skin. And that's why that toddler I talked about, the 100%, that's why we couldn't save her. Okay, here's a scald burn. This is kind of classic. This is a deeper scald, and I think it was probably a stove top that actually missed the top of the head, fortunately. But it's definitely something hotter. Because you see this little white, that's like almost like a thin layer of dead skin. It's translucent. And a lot of times with dressing change, it'll come off on its own, and they don't have to go to surgery. But if it's like that thick white stuff, then they're definitely going to surgery. So this is what we call a watcher, when it's mixed like pink, and this is almost like, we call it a yellow wound. It's kind of yellowish. So that's a wait and see. If within 10 days or 2 weeks we don't see that yellow come off, then we'll probably send them to surgery and let them surgically remove it. But a lot of times with our daily dressing changes, it'll slowly lift off and then it'll all look pink. If it all looks pink after like 10, then we know they're going to heal on their own. This is a face burn. It's not that deep. You can see a little bit of blistered skin, but really it's like a shallow 2nd-degree burn. It's probably going to heal up like in a week and a half to 2 weeks. The only problem is it's the face. So when you see an injury like this, if it was a flash flame, one of the problems with flash flame burns, which is the thing when you throw the gasoline and all of a sudden a big fireball shoots up, you can breathe in superheated air, and so it can actually compromise your airway. So this is the kind of kid where they go to the ED, you might transport them, and then And then the kid's on the way home, halfway home, he begins to breathe funny, and they do a U-turn back to the ED. So we would probably keep this kid for 24 to 48 hours. You know, that's the time that the edema would run its course on an O2 sat monitor. Okay, this is a handgun. Once again, it's not that thick white that you see, it's that thin yellow, but it's involving all the digits. So this is another wait and see. So if this kid does heal on their own, they're going to require a lot of physical therapy, a lot of range of motion. But sometimes after it heals, if there are scar bands, even like relatively small ones going into those joints, they actually do revisional grafting. They cut up the scar bands, break it up. They might even put a little piece of skin on there, but you have to maintain the mobility. So these hand burns, these are one of the burns that we talked about that really, you would think, oh, you know, even a pediatrician's office could think, oh, I can treat that, you know. But they really should go to a burn. Face, hands, feet, you know, all that stuff, genitalia, should all go, because there are areas that if they get any even a small amount of scarring, you're going to lose function. And you never want to lose function, especially with a child. Hypothermia we don't really see. It's usually someone passing out in the snow. Although we did have 2 teenage boys, obviously teenage boys, but they were walking to a pond and their boots filled up with ice water. This was like 3 years ago in the winter. And then they decided to walk home and they got frostbite. And it was like, why did you walk home with ice water filled in your boots? It was like, I don't know. You know? So anyways, if you should get ice water in your boots, it would probably be smart to empty it out and not walk home with it. Okay, this is a chemical burn. But this is a bad chemical burn. A lot of our chemical burns just look like a bad rash. You might get some little bit of blistering, that kind of thing. It could be from concentrated bleach detergents. It could be either acidic, it could be alkalotic, anything that really irritates the skin and then causes like surface blistering. But this is a whole other. I wanted to show you this because, you know, a lot of lay people see this and they go, oh, did they amputate that leg? And the answer is absolutely not. This was a teenage boy. And he's a high school student. He had to take a summer chemistry class. He was wearing shorts and sneakers with no socks. And he started the experiment before his teacher got there because he wanted to get a job. And he thought he had a beaker of water. It was a beaker of hydrochloric acid. And so he spilled it on his leg. And of course he started to run around rather than just flush it out really quickly, which is what you always want to do with a chemical burn. And this is what he ended up with. But what they did is, see all that black, they took him to surgery and they scraped it all down because the bone tissue is vascular. It has little blood vessels going through little tunnels all through it. And so all they had to do was clean all that, scrape all the bone down, and then they have to wait for it to granulate over. The human body is amazing. You'll get soft tissue will grow all over that again. So, you know, in about 3 or 4 weeks, it actually looked all, you know, soft and red. He grew back all this soft tissue, and then they were able to just grab some skin and graft onto it. So he's doing fine today. He has some scarring on his leg, but you know, it's his war wound. You can tell stories about it now and stuff. But he's fine. He didn't lose his leg. This would never happen. But this isn't the case with this kid, okay? Another teenage boy. And he was down in a resort in the Caribbean. They don't have the same kind of coating. He was on a sailboat holding onto a mast. And somehow the boat got pushed under a railroad, or it was just a bridge of some sort. And they had high voltage lines strung underneath. And the mast cut into the high voltage lines while he was holding onto the mast. And so, fortunately, somehow he broke free from it, or else he would have certainly died. But we did have to amputate below the elbow, and he has a prosthesis now. He's doing fine. One of the things you have to do in electric burn is you should always put an EKG on, do a cardiac check, or even if you just listen to the heart rate to see if it's irregular or anything. Because if this happens much more frequently with an alternating current is kind of a pulse current. It kind of pushes electricity, like, you know, through, where direct current just sort of zaps you, okay? So I think this was probably direct current, because this kid had no cardiac damage. I remember thinking, this kid must have like some kind of heart problem or something, but nope, he didn't have any cardiac damage at all, but his hand really got fried. Okay, that's like down into the muscle, bone, nerve tissue. The thing there is, they could have even made, well, they probably couldn't have. Even if it was a little bit bad, but if you destroy the nerve tissue, which has happened with some of these burns, some of them haven't even been that bad. I've seen burns where it looks like about a quarter went in here, and then a quarter went out the elbow. But then all the nerve tissue was destroyed, and you know, the kid's saying, "Oh, don't cut my hand off; it looks fine." But what would happen is that hand would just mummify, and, you know, it's better just to amputate it and give him a prosthesis. But in this case, there was no doubt that this kid, and he's doing fine today. He's actually graduated college, and he's doing well. And this is a regular sunburn. Some of them get pretty nasty. We've had listed ones. We call this the prom wrecker. It is a teenage girl, fortunately, finally. But yeah, so you want to get a nice tan, to look good, and all of a sudden you get a bad sunburn, and now you don't want anyone to touch you, so pretty much your plans got wrecked. Okay, how severe the burn is the next thing. So we use first, second, third, fourth degree all the time among ourselves. But if you were if you were reading a burn journal or a textbook, it would be superficial, partial thickness, you know, deep, partial, and full thickness. It just sort of describes, you know, how much of the skin is involved. So all of these layers right here. Okay, you go to the next one. Okay. I won't go through all these. These are all the secondary glands. They all regenerate back, by the way. You know, the body's amazing. Okay, so this is the first degree burn right here. So basically your skin sits on a capillary bed, and as long as these capillaries aren't injured in any way, this is a sunburn. You're going to heal up within 4 or 5 days and feel better. One of the things that a lot of people don't realize with skin tissue is it looks like it's going straight across, but actually this thing is called, where the follicle is, it's called the follicular composum. And that follicle is lined by epithelial cells, which is why if you have a second degree burn, you're still going to heal. So you have to think of the skin as like an egg crate, okay? And so it's very convoluted. And so what happens is if you get burned like down to here, like maybe mid-shaft, all those little follicles, they're like 1,000 per square inch. And it's everywhere in your body, by the way. So on your face, you know, like on a woman's face, you go like, I don't have any hair on my face, but you do. It's subcutaneous. It's called vellus hair, but it's hair that's underneath the skin that you don't see. But this structure of the skin, this convoluted structure, is the same way throughout the whole body. And so what happens is if you get burned, those little capsules open up. It's called blossoming, and as they all open up next to each other, they sort of join each other, and then they proliferate upwards, and that's why you get healing with second-degree burn. If all of that capsule is gone, though, then it's full thickness, and the only way it's going to heal is from the sides in. So it's a really interesting phenomenon about how skin can heal. Okay. So now you see that the capillaries are involved. So that first one was the first degree. This is a second degree burn. So whenever the capillaries are thermally damaged, they're going to leak. And when they leak, what happens? You make a blister. And a blister is a hallmark of a second degree burn. So you see blistering, you know that it's down into the dermis, okay? But you still have plenty of skin cells for healing. So I angled this one down intentionally. So here you have this little bit of skin cells. It's going to open up, okay? And they just, if they're all like this, they just about will join each other. But what's happening down here, if that opens up, they're not going to join each other. So you're going to get back into that lateral healing. So this is that thing we call a watcher. So we may end up grafting for this because it's going to take like 7 or 8 weeks for this to heal. And you can't keep a little kid open for that long. They'll go completely out of their mind. Because kids don't acclimate to the hospital. Every dressing change, they get more upset. So finally, you just walk in the door in the morning and the kid jumps 2 feet out of his bed. So we really have to move things along. So, and cosmetically, you probably get better results anyways. So if you have a really deep burn like that, even though it's not truly full thickness, it may be better to go ahead and graft. And then the last slide, and now you have definitely a full thickness. This is his primary blood supply. This is a secondary microvascular, but this is actually little veins and arteries. When that's damaged, that's when you have that white, like that first picture of the guy, because all those blood vessels are damaged, and the skin's going to look completely white because it's called a vascular tissue or non-vascular tissue with no blood vessels. Now you go, oh, what do you do now? Believe it or not, all of this regenerates. All those blood vessels have an amazing ability to like regenerate. Because wherever it ends, it'll start to grow off of itself, just like, you know, kind of like split ends, and they just, you know, reform a whole new vascular bed. It's just amazing. And then as you get that vascular supply going, you get new tissue being built. And then once you get that tissue that has blood vessels in it, it's called granulation tissue. That's what you can graft onto. Even if you don't have any skin cells, then you'll have to graft. If you have enough skin cells, you'll begin to grow new skin. Okay, how big is the burn? So the basic tool for assessment in burns is the rule of nines. Okay, this, you might call it. There you go, okay, 9. So basically it breaks everything up into 9, okay? The arm is each 9, the chest is 18 front and back, okay? So it's a total of 36. Each leg is 18, okay? All adds up to 100. And that, okay, next slide. The only problem with that is it came out of the military, it came just around pre-World War II, and they think everyone's an average sized male. So obviously that doesn't work in pediatrics, so next slide. So we use a conversion. London Browder were 2 famous burn surgeons, and they had this conversion chart. You can see the infant head is 18%, and the adult head is 9. It's just because infants have really big heads and small bodies, and so we have to adjust to that. So if we know we have an infant with a big, other than that, everything's relatively the same. You know, the torso size is about the same, so and the leg size is about the same. But we do have an actual, this is what our actual chart looks like, that the doctor or the nurse will actually, and what we do is you can see that it's the shoulder, it's the intercubital, it's the elbow, it's the wrist, it's the knees and ankles. So basically you use all the anatomical landmarks, you use your belly button and that kind of thing. And you can, it's like connect the dots. And so you go from one anatomical landmark to the next, and that's how you kind of join everything, and then you can get a pretty, usually you can get within 2 or 3%, which is what you need to have your formula work. There's also the Palmer method. This is used a lot by EMTs. You just use the palm of, it has to be the victim's hand, so that's actually my hand, but it's, so it would be like 1%, my body surface area would be 1%, probably a little bit more, but if it was a small infant child, what I do is I just take my finger. So if it's a little child, I just kind of go like that, and then I estimate the size of the burn doing that, because it is the victim's hand, it's not your hand. Because your hand on an infant would be like 5%. So here's a burn to the chest. Okay, probably looks like it's a regular cup of coffee, classic skull burn for a toddler, and so it looks like it's about 1/3 of the chest. The chest is 18%, so we're probably looking at, I think, 7%, maybe a little more. We use the Palmer method. We see 1, 2, 3, 4, 5, 6, 7, so 7%. Yeah. So that's how you would estimate. Okay. The other thing we do in assessment, we want to be able to communicate things very effectively. So we use this kind of, rather than go second, third, fourth, and that kind of thing, or first, second, third parts. Sometimes we just describe a wound by color, and it'll give you an idea, because a secondary burn, a red wound is always second, yellow is a deeper, white is full thickness, and then black is black. That means it's cooked, and that's always a weird thing. But, okay, so that's a regular, oops, sorry for that. That's a red wound, okay? It's a classic pink, it's a second degree. It's probably gonna heal up on its own in about a week and a half to 2 weeks. This is tricky. This is an abuse pattern. It's called stalking feet. When it's beefy red like that, it's going to convert to a deeper wound. It's deeper than it looks, so you have to kind of watch that when you see that kind of deep red. When I say red, I just mean like pink red, but this is like deep red.
What caused that burn?
That's an abuse pattern.
Dipped them in the water.
So this is a yellow wound, and it's that thin layer of eschar. We have different types of topicals that can, called the breathing agents, that can actually help lift that away. So I think that this child did heal on his own, which was nice. But like I say, we use a 10 to 14 day window to see if all that's off. If it's not off, we'll surgically remove it. And then there's the white wound. You can see the escharotomy. All that white has to be taken off. You have to take skin from a non-burned area, put it on that burn wound, let it heal. The black wound. Okay, so the black wound is really, really nasty. Okay, this is obviously just a hand, so it's like maybe 5%. I don't think we've ever saved a black wound greater than like 20, 25%. Just to give you an example, we had a teenage boy who in one of the Boston suburbs, and he decided to sneak into a hockey rink. And so he was climbing the fence, going onto the roof of the hockey rink, and there was only like 6-8 inches between the fence and the building. He was wearing like a down jacket, and he fell between, and as he fell down, he pulled some wires loose, and it ignited his jacket, but his arms were pinned down. And so the jacket was burning and burning, and he's screaming, and finally people run out. They put the fire out. They call, the fire EMTs. They cut him out of the fence and they brought him in. And I remember when he came in, so he went right to surgery. And when we saw him the next day, you could see the covering, you could see the rib cage, and you could see like the covering of the liver and stuff like that. And it was just all gone. It was like a big defect. They just removed all that dead tissue. So now we had to wait. Like you can't graft on a bone, you can't graft on a muscle or tendon or anything. It has to be soft tissue. And so we said, well, all we can do is wait for it to grow, okay? But there's a lot of soft tissue that's gone. And so this kid was out, and it was 14 weeks before he had enough soft tissue that we could graft onto it. But all during that time, he kept on getting there's no way you can keep him infection-free as hard as we try. And so he got an organism, a germ that was really resistant, and we couldn't find any combination of antibiotics. So here he was, already to get grafted after weeks and weeks of going through this, and he got a really bad infection. He became septic and he died. So this is what happens with these really deep burns. It's just, you can't, fourth-degree burns are a whole other category. It's always someone who got trapped like in a motor vehicle where the arm was trapped and the rest of the body was outside. But it really gets cooked. Basically, it's completely burned, tissue. Okay, abuse and neglect. This is another abuse pattern. It's called gloved hand. The feet that you saw, it's called stocking feet. The classic burn abuse patterns. Abuse and neglect. Abuse is intentional and neglect is unintentional, but we still report with a fee in Massa, it's 51A for Division of Youth Services. The reason why is abuse, of course, it's intentional, so there's no. Neglect is like a single parent who might have 3 preschool kids, and the parent's feeding the infant, the 2 and 4-year-old are playing in the bathroom unsupervised. All of a sudden, the 4-year-old turns on the hot water, the 2-year-old falls in the tub, gets a bad burn. So whose fault is it? It really isn't anyone's fault, but then you have to keep a lock on it. You can't let a 2 and 4-year-old play in a bathroom unsupervised. Now, I guess said how toddlers have to be supervised really closely. So we might file a 51A. 51A just means they're going to investigate. It doesn't mean they're going to run in there and pull the kid out. It means that the DY is going to go in there with a caseworker, talk to the parent. Sometimes they even get services. You might get a home health. They may get a home health aid. They may get money for locking the door. The other thing that happens really frequently is a lot of times the water is turned up really hot. With toddlers, the hot water should never be greater than 140 degrees. But some of this water is like 170, 180. That means if you put your hand in that, you'll get like a burn within 1 or 2 seconds. And so the caretaker, the parent will say to the landlord, could you turn the hot water down? And of course the landlord will go, yeah, when I get over there, I'll do it. But then DYS comes in and says, we're going to fine you $500 a day until and he's up there like in 10 minutes turning it down because he doesn't want to get fined. So sometimes it's helpful to have, it's not always a bad thing. So we look at the circumstances around the injury, we look for old injuries, that's called the trauma workup. We see if the story makes sense, that's why it's investigated. We always send a social worker out, they take pictures and that kind of thing. They measure the temperature of the water. So if it's 130 degrees, that means it takes like 5 or 6 seconds to get a 3rd-degree burn. So just count 6 seconds. Put your hand on the hot water. 1, 2, 3. No one's going to do that, So if they're saying that, they were washing their hands and they got burned, it can't be true, because no one's going to keep their hand on the hot water for 5 or 6 seconds. Delay in seeking medical treatment, that's a big sibling thing. If you have like a 12-year-old taking care of a 3-year-old, the 3-year-old gets burned, maybe a scald burn. The 12-year-old thinks that if they put the PJs on and put them in bed, the 2nd-degree burn will be healed by morning, but it doesn't work that way. And so we get a delay in treatment. Okay, so burn pattern's very important. This is gloved hand, stocking feet, immersion. And then we see branding a lot. Okay, that's when someone intentionally, sometimes it's accidental, but sometimes it's intentional. So this is a case I just wanted to show you. The mother was a very attentive caretaker. Didn't follow the pattern of an abuser. And the story she told was that she was ironing, and she pulled the bassinet close to the ironing board so she could just talk to the child. But then her cell phone rang, and she turned to answer it, and somehow the iron got knocked off and bounced off the child. Well, actually, that looks true because it's called something we call a partial brand. It isn't like you see, the exact outline. It's like a half. But the reason why we had to report a 51A is you wouldn't pull a child underneath an ironing board in iron, you know. At the very worst, it's very poor parenting judgment. And I know none of you guys would ever do that when you had children. You just don't do that. So at the very least, it was kind of neglectful. And so we felt it still warranted an investigation. So the investigators went in, DYS investigators, and there was a 2-year-old with clear signs of abuse. What happened was the boyfriend was abusing the children, the mom was enabling because she got. So these are the complicated social situations you get into. So usually, you know, in our rule of law, it's like you're guilty until you're innocent until proven guilty. It's almost in these abuse cases you have to think in reverse. You know, it's just it's as difficult as it is. These kids have to be protected. Any kind of child, spousal, elderly abuse always has a tendency to escalate until finally something really tragic happens.
Larry, on the iron one, if that were an accidental ironing on the infant, you would see more signs of traumatic, some trauma.
Yeah, something like that.
Than you would
Like-
just like that little outline.
Yeah, some of these irons are pretty light now. We thought of that. You know, some are heavy, some we didn't know. Actually, they did get the iron, and I don't know what the final impression of it was. But there was no trauma. There wasn't even any bruising or anything. So that's a good point, right? You know, that's a very good point actually. I don't know if we thought of that at the time, but you probably would have had burns.
I don't want to work in that burn.
Yeah, you know, I mean, you're right. If it would only be a couple feet from the iron, but if it fell a couple feet and it was a heavy iron, you probably would get bruising. Okay, I just wanted to give you a critical burn piece, okay? So all the other burns you've been looking at are these smaller skull contact burns. But, you know, when we do get a big house fire burn, that person goes into a whole other different category. It's literally, you know, life-threatening for a considerable amount of time. So here's a big burn. So they have it's a house fire. And you can imagine what being in this building is. So there's always a window, and it's probably sometimes it can only be 3 or 4 minutes. So if it really flares up like this and a person's in there, if first responders aren't in there within that 3 or 4 minute window, that person's going to die. If they're in there before it flares up, there's a good chance they rescue the person without them getting a significant burn. But there's a middle road piece, okay, and it's actually a fairly small window where they get badly burned, but they still survive, okay? It's not like they could be in there for 15 minutes. So these burn victims that get these big burns from house fires, in a way they're very fortunate that they even made that window of survival, because it's not like this long period of time. It's not like 15 to 20 minutes. It's a very short period of time. And so first responders just happened to hit it right and get there just before the person got so badly burned that they couldn't survive. So they thought this kid was playing with matches. So right away we do our airway and breathing. We see the face burn. I'm sure he has erythema. By the way, the definitive diagnosis for lower airway injury is a bronchoscopy. If you see soot, they would do that in the hospital, but if you see soot in the lower airways, then you definitely have inhalation injury. So it's history of an enclosed space. It was a house there, facial burns, plus it's a very large burn. So all those point to inhalation injury. You're going to get a couple large bore IVs in. You know he's going to need a lot of fluid. You're going to do the TBS area, quickly going to keep him warm, going to keep him close, you know, monitor his temperature. So you estimate his weight to be 60 kilograms using the Lund-Browder chart. And so now you have the whole torso is 36% back and chest. His arm is 9%, whole arm. His whole left arm is 9%. His face is about half, or about a third, that's 6%. Perineum is complete, so that's like 27%. Okay, so this is what this burn looks like. This is what an 86% burn looks like. Now I know you guys are all looking at the red, because that's, you know, but actually what I'm looking at is the burners, and I'm looking at the white. I'm looking at the unburned skin, because that unburned skin is what's going to save this person, okay? You know, the dead skin is dead, it's gone, it's going to be removed surgically. But so actually, believe it or not, looking at the lower legs, the thigh, and the scalp is a very good donor site, by the way, because they split the skin in half to keep the follicle intact, and so they'll grow hair back. But I actually see 2 donor site areas, okay? So you're looking at like 14%, and they would never like take all of the donor site, because if they took all the donor site and the person didn't, something happened, then they basically kill that person because, so they would take half of that. So they would probably take skin from the lower legs, and then they would take skin from that left hip and scalp. So the two separate, so then they can take, it's gonna be like 7 to 8% for each one. They actually mesh it and expand it, so twice the size. So now that 8% is gonna be, 7 to 8% is gonna be like 15, 16%. So that 50, what we do, there's actually a strategy. So when they have this, when they're doing this grafting, they're taking this donor skin, they're gonna do the entire interior first, because it's gonna have the best chance of healing. If you put them on the back, you're always gonna lose some grafting. You know, even though we have excellent negative pressure beds now, they're incredible. There's, you know, they're sort of air-filled and aerated, it's just amazing. But we're gonna do all the interior first. Typically, they do the torso to get that done, and then they do the upper extremities and the lower extremities, and we actually follow. It all has to do with, because the thing is, you can raise the arms up easily, minimize the edema, so you're going for the best shot of healing possible. They usually leave the face and hands to last, because they actually want a lot of soft tissue growth, because they don't want to remove too much, especially from the face. So they'll do the torso, upper extremities, lower extremities, and so they'll do it 15% of the time. Let's see, we can even narrow it to 16. So you go from like first 16, and you have 70, and then you have like 60, and then you have like 45, and then you have 30, and then 15. So this person's going to go to surgery 7 or 8 times, and then they'll go like 1 or 2 more times for patchwork, get the face done, get the hands done. So probably about 10 surgeries. But within 10 surgeries, this person will actually be covered, and they'll be covered using the skin from those white areas, and that's it, okay? But they just go back and forth, back and forth. Okay.
10 surgeries over what period of time?
It's usually 2 weeks, but sometimes they leave like a week in between. So if you do 10 times 3, it's 30 weeks. 4, 8, yeah, it's a lot.
And what is their chance of survivability and their chance of infection?
At 86%, this is weird. It's sort of ballpark now, but at 86%, we say they have an 86% chance of survival. Of course, 90%, then it would be decreased, and then so we just sort of 80 is about 80%, and then it goes up, then you go down, and then as you go down, you go back up. Okay, but that's interesting. This person's an 86% because 80% burn gives you just enough skin that you can make that. When you start to get to more and more surgeries, and every surgery they get a little bit weaker and stuff. But actually, now that used to be 50%, and it would be adjusted up and down. And then, over the last 20 years, it's been 60. So now we're at the 80% mark. Okay, so an 80% burn has about 80% chance of survival. If they go up to 90%, they have about a 70% chance of survival. If they're a 60% chance, then they have like a 100% chance of survival. No, I shouldn't say 100% because that's never true. Maybe I should say like 95. You never know. I mean, especially with smoke inhalation, they could always just get a really resistant organism. But we're so good at infection control. I mean, statistically, we actually are there, but other burn units may not have that kind of track record. This is sort of our track record, and we're just really good at what we do. So I won't go through the whole Parkland, but that's it basically. And there's urine out the golden window, what I talked about before. You're going to get dry clean dressings as you transfer them, and then that's it. Every day they're going to get daily dressing changes. They'll go to the OR to get cleaned up. Surgically, they'll get a lot of topical antimicrobial therapy, and they start excision and grafting right away as soon as you can. So for a second-degree burn, we just use regular topical ointments, regular broad-spectrum antibiotic ointments until the wounds heal. That's those second-degree burns. These are new products. Silver's a very effective antimicrobial because it coats the organism wall and destroys it. So these type of, it's called crystallized silver dressings. And the good thing about that, you can only use them on smaller burns that are second degree or like shallow second degree. And that's like a lot of these little kids, like they'll burn their arm, or they'll burn their chest, like the one you saw, that teardrop. These are very good because you can leave them on for 3 or 4 days. So now we do a lot of treatment. Our outpatient department, where they used to see like 500 kids a year, last year in 2012 they saw 5,000 kids a year in that year. So it's really been tenfold. It's because of stuff like this. You can put it on, you can leave it on. But it can't be like a full thickness or a really deep burn, because it won't be effective enough. But for a shallow wound, like a regular blistered second degree, they're actually pretty effective. So you can actually send the kid home for 3 or 4 days rather than do a daily dressing change. So again, it has to be a smaller burn. That isn't too deep. These are the debriding agents, and that's for those yellow wounds that I talked about with the thin eschar. You put this stuff on there, and it softens that yellow. And when you put a dressing on, when you take the dressing off, it actually takes like a layer of dead cells up with it. And then you do like maybe several dressing changes, and you get all that off. And then you can avoid surgery. These are the standard creams and stuff, again, for second-degree burns. You just put this on, and we clean it off, and then we like see if the wound's going to heal. Again, that 10-day to 2-week window. Okay, so here's the silver nitrate. Here's the wet dressings. Okay, the thing with the wet dressings, we use them for really big burns. So what happened was, years ago, like 25, 30 years ago, they didn't want to give kids opiates because they thought, their undeveloped respiratory systems wouldn't be able to handle it. And so a lot of times they under-medicated, and these are kids with like significant burns, and they would actually under-medicate them. They were like incredible pain. This was about the time I came into burn care. So this burn doctor came, so if you put the creams and ointments on, it's not bad if you have one arm, but if you have like most of the body, can you imagine scraping that off? In fact, for 9/11, the adult burn unit, Cornell University, the burn center, we sent nurses down, and they were using creams, and they just slathered this all over the person. And the next day, they would have to actually take them to like a big tub room and shower it all off and get it all off, to scrape it all off. And of course, the adults, well, this is an adult burn unit, and they're all heavily medicated. But they weren't, if they did this with children who weren't heavily medicated, it's basically equivalent to torture. And so this doctor came along and said, you know what, let's get away from the creams and ointments and stuff. Why don't we use a clear solution? We'll put a bulky dressing on, we'll wet it. The next dressing change, you just take the bulky dressing off, you clean up a little Exudate, and then you're all done. The only problem is they're going to be wet all the time. So, next slide. So we had to make a bubble that was heated, okay? Because there's no way that you could keep a kid wet all day in a regular room. They would freeze to death. So this is heated to 86 degrees. Initially it was just heated, but then later on we added filters to it. So there's HEPA filters in the ceiling. The air sucked through a grate in the back, filtered and comes back down, so it increases the organisms floating around. And so it's very effective. Of course, it's very difficult for caretakers. So there's a split in it. We do routine care by going inside. I don't know if you've ever seen like chemists in the hood and stuff like that, but it's similar to that. And okay, so like I said, how do you heal an 85% burn? I kind of went over that. You just, you got to keep them. You got to keep them, keep a close eye on them, keep them well monitored. Nowadays, they're really narcotized. You got to keep them. You got to culture all those wounds, keep them infection-free. Until they're completely closed, you have to keep them all hydrated. So all of that. Okay. This is just an idea of how many. This is all the people that are on the burn team that actually, care for these burns. So it's a pretty significant cast of characters, and they're all needed. They all have essential roles in, in getting this kid back, to where they need to be. These are the general phases. The shock phase is 48 to 72 hours, and that's the most unstable. They're very hemodynamically stable, and we have to watch them very, very closely, and it's just really, challenging. The acute phase is considered to be acute until they're completely healed, and that's when they can get one of these nasty infections and even become septic and die. And then the rehab can last a really long time. In fact, they really say, if you've lost digits or something like that, it's really the rest of your life that you're adjusting to that, whatever. Okay, so like I said, you've got to get rid of all the dead skin. You're going to usually take up half of the available donor. You're going to mesh it. You're going to apply it to the wound. Anything else you're going to cover up with an artificial dressing. And then you just repeat until everything's covered. So it's just very, day after day, week after week. Okay. So this is the dermatome. Like I said, it's like a vegetable peeler. So they get scraping that dead skin off. The one on the left is a manufacturer's slide. I've never actually seen a dermatome that big. I don't know where they got it. One of the doctors gave me the slide, but I've never seen that. I've been in the OR before, but usually they're smaller than that, like the one for the hand. And they just kind of like, they don't just back away. They really do it sort of controlled. you know, they have to be careful, they don't want to take any good tissue. So I don't know where they got that thing. This is that dermatome. It's a blade that oscillates 1,000 times a second, and it's laser guided, and all they do is they drag it across. It literally splits the skin in half. So it takes half the cells, and it leaves half the cells. This splits it right in half. It really is kind of a marvel of engineering, and that's what they do. So next slide. So here's a hand that was, so what they do is they mesh it, they put it on, they either staple it or stitch it down. Now they're using the surgical staples a lot because it's so quick.
The last slide said that they're not doing cadaver anymore, or?
Yeah, they do. That's that biological dressing I told you. But they have other things
But I
now.
thought you said you can only have one.
Yeah, they only use it temporarily. And eventually it's going to be jacked off. So believe it or not, the cadaver skin will stay on for 2 or 3 weeks. The donor site takes 2 weeks to heal, and the autograft takes 2 weeks to heal. So it's kind of like this little dance where everything's healing within the 2 or 3 week period, or it's rejecting. But nowadays they have stuff like transderm and offset. They have all these artificials, basically porcine or bovine collagen on a silicon base. And the thing is, it's shelf stable, okay? So we use some of that, but believe it or not, some of the surgeons really like the cadaver skin. So we still have our skin bank that's located, you know, on site. And it's because it's very durable, and it's very much like, you know, it is human skin. So it has a tendency to be a little more durable, because you really want it to last at least 2 weeks. If it doesn't last 2 weeks, now you have to go and put another, you don't want to take them to surgery. You want to take them as least frequently as possible. So basically that's the burn nurses code. Good hydration. Nutrition is incredibly important. You're building a lot of soft tissue. We have a rule. We absolutely do not let our kids fall below the caloric goal. It just doesn't happen. Whether we're giving them IV, you can give IV nutrition called parental nutrition. Of course, you can give the tube feedings, right into the stomach tube, or they can eat regular food, and we transition them from phase to phase, but we never let them drop below. We've seen really clear evidence that if they're not getting good nutrition, even completely stop wound healing, or you'll significantly slow wound healing down. So one of those little things, you wouldn't think it would be a big thing, but nutrition is huge in burn recovery. So if we have a major, like you're doing a full dressing change, the nurses gown up just like going into the OR, and they go right in that bubble and they do their work. Otherwise, they do the routine care like vital signs and those kinds of things from outside in the split. Okay, so the units are actually pretty versatile. But I'll tell you, being in those 86 degrees for like 2 hours, it's like being out on a day like this. Okay, infection control is huge. We never do prophylaxis in burns now, because that means that you don't know what the organism is, so you just kind of give a general antibiotic. You don't really want to do that, because the whole idea is you want to identify the exact organism, match it up with the exact antibiotic, and that way you knock it out very quickly, because you don't want to build up resistance. Because we lost a lot of burn victims. In fact, I think that kid I told you about that was the 4th degree, I think he developed a resistant organism, and that's what killed him. So you really want to be careful of that. A lot of blood cultures, a lot of regular cultures, culture other things like urine and sputum, because those things can migrate to the wounds. And then once you find what the organism is, you give them the exact drug, knock it out quickly. So they didn't want to give kids pain medicine, which was like torturous. So what they did is all through the 80s, they did these major pediatric studies on opiate metabolism. And basically what they found out is you can give kids powerful drugs, powerful opiates, but you got to monitor them very closely, and you got to dose by weight. And you always start on the low end of the dose and then work your way up until you reach a degree of effectiveness, because you don't want to overdose them. If you overdose them, you're going to get in trouble. And so you just have to kind of be patient and start on the dose and then work your way up. And then finally you get, and so basically what you're looking for is, if you're not doing anything, you want the kid to be quiet, comfortable, sometimes even sleeping. So nowadays, you walk to the burn unit, you would think you would see kids jumping out of the bed. No, they're sleeping most of the time, they're resting, it's very quiet. Burn unit's actually a very quiet place. Dressing changes, you might hear a little bit of yelling and that kind of thing. The only way you can take all the pain away from that is if you get general anesthesia, which you shouldn't do, because, getting general anesthesia every day could be very harmful. So we try to give them as much, we give them both. So the whole idea is that nobody suffers, okay? So as soon as you're done doing whatever it is that might be painful, that child should be back relaxing again with, normal heart rate, normal blood pressure, that kind of thing. If not, then we have to adjust the medications and go up on them. We also use a lot of tranquilizers and stuff, which is really good in conjunction with our narcotics. It really keeps them quiet, settled. Okay, scars, huge part of, the scars reach their peak after 4 to 6 months, and so you sort of have to have a long-term plan for it, like how you're going to address that, the plastic surgery and whatnot. But if you have burns, then you're going to have burn scars, and there's no way around it. Hopefully they'll be minimal. If they're more significant, there's all these plastic techniques that you can use to manage the scar, but it really is a challenge. So one of the things is we use pressure garments. Pressure garments, if you have a burn scar, for the first 6-7 months, it's actually soft. Later on it becomes very dense and hard. You can't do anything with it. But you can actually, it's almost like silly putty. And if you put pressure on it, you can flatten it out as it begins to grow. So you can actually manipulate it and shape it. So if you do these pressure garments, put them on, the scar tissue will actually become flat. It'll look like normal skin. Otherwise, scar tissue looks raised, red, and bumpy. But if you flatten it out, then it almost looks like the regular suit. So the thing is, like, how would you like to wear a really, really super tight bicycle suit for like 7 or 8 months? I mean, it's a big buy, and you have to really, get the kids to, to buy into it. And for the most part, they do pretty well. Some of the teenagers, are more resistant. But it's like basically, if you do this for 8 months, then your skin will look like flat, pretty good for the rest of your life. So, you really just have to convince them. So, kids are funny. We have a school reentry program, and nurse, therapist, and that kind of thing. One of the child life people will go out to the school, and we'll answer all the kids' questions. So it's a chance to do some prevention, but also it sort of breaks the ice, because kids will go, oh, will that skin fall off and stuff like that, like the crazy things that they get in their head. So we sort of have to run interference. Sometimes we invite friends. We have a program. So before, if you were in an ICU, you couldn't even have your siblings visit you because they're afraid of, like, communicable disease. Nowadays, we just do a screening. So we have siblings come up, we have friends visit, all of those things, and that sort of keeps the kid engaged. One of the things that kids go through in the hospital is called disengagement, and they actually become like they're like in a different world. And when they do that, they become very anxious and angry, and they become non-compliant, and they're generally very miserable. So we try to do things. The other thing is things like with sports and hobbies. If a kid burned his leg, teenagers are a little bit better in this case, but some of the young kids, if they get hurt, it's like, oh, I can't play soccer anymore because I burned my leg. It's like, yeah, you can play soccer again, So what we do is in the gym, they'll get a soccer ball and we'll have a soccer game, and they'll make the kid like kick the ball around and stuff, and then he knows that he can play soccer. But they get the crazy, like they want to almost like they want to stay sick or something, but they get into like this sick frame of mind, like, oh, I was burned, I'm never going to be normal again. And it's not true. So we have to sort of convince them before they actually leave the hospital that there are things that they can do that they did before. So this is really bad scarring. I'm going to tell you, one of the things that we do is we have an outreach for, basically it's worldwide, but it so happens that some of the local clinics are in the Caribbean. So I always tell people, don't get burned outside the United States, because all these countries are 30 years behind us in technology. It's outrageous. They don't have anything like the dermatomes or the skin split or anything like that. And so they literally do what we did. They wait for the burns, skin to fall off. They wait for lateral healing. And so this is the kind of stuff you get. Like this, I think this kid was from Costa Rica, and basically he got burned when he was very young. Didn't get any of the advanced burn treatment. Got massive scarring, and he could hardly use his arm. So here he is. He got burned like when he was like 7 or 8. Now he was like I think 13 or 14 when he came to us. So he went all those years unable to use his arm. I just can't imagine it. So he came up to us, we released all the scars, we regrafted everything, and he went home using his arm. Because it was only the scar tissue, muscle, bone, nerve tissue, everything was safe.